Hello. Hi, everyone. Thanks for being here at the afternoon session. I know sometimes it's tough to pull ourselves in. I think there were supposed to be 40 that were coming today, and I thought 4:15, networking, the bar, maybe I would have around, 20. So I'm glad that you guys are here, so thank you for coming. This session is Florida Medicaid Managed Care, What's New? In lieu of services benefits, specifically the benefits related to Sunshine Health. So what do we have in our contract? What are the new services for us? So first, let me get a show of hands, not a show of hands, but I just want to see who in here is a gal? Most of the people. Okay, lawyers? Judges? Any other professionals, child welfare workers, other health plans? Hi there. Yeah? Well, welcome. Thanks for coming. So my name is Melissa Mott, and I'm originally from Alabama, but I claim Florida is my home. I'm a licensed marriage and family therapist, and I graduated from the Indiana Wesleyan University with a psychology degree and an undergrad in addictions. And I also played college basketball there, which is why I currently have a sling on my arm. A lot of people have been asking about it. So it was a basketball injury that I did not take care of very well, clearly. And 17 years later, 3 weeks ago, I had surgery. So I'm on the mend. I'm not in pain. So I appreciate everyone that has expressed concern and opened doors for me and gotten me free things. So I might ride that out for a little bit longer. So after I left Indiana Wesleyan, I received my master's in marriage and family therapy from the University of Kentucky, and I started my career at a large community mental health center where I was a service coordinator, so much like a targeted case manager. I moved to be an in-home therapist that worked on a team structured much like the CAT teams here in Florida. And then I became director of the children's program. And so we had therapists that would go out to the school during the days. We ran parenting group during the days, and we would go into the schools when we needed to during the days if there were any type of emergencies or we need to go see a child because they were having a rough day, okay? And then in the afternoons, we would go and we'd pick up all the kids. My team would go bus and pick up all the kids, and we ran an after-school program for children, including their families. So my background in education, what I truly believe is the child is part of the unit, and the family is super important to be a part of treatment. As a matter of fact, you couldn't be a part of the program that I ran. You couldn't just drop your child off, and then we didn't see you again. We had family fun nights. We had groups that you had to be a part of. And if the parent wasn't actively being a part of that therapy treatment, we would say, your child couldn't participate. Of course, we would take care of our children, but that was really our push to make sure that our kids were taken care of. I also ran every Tuesdays and Thursdays a court-ordered teenage girl group. So these were some of the meanest, most hard to difficult, my favorite population in the world to deal with, and I could only manage about 8 of them at a time because they would hurt my soul, because we know we all work with these children, right? So I also did some work, so there in that community, 95% of the population in Versailles, Kentucky, or 5% of the population in Versailles, Kentucky had 95% of the wealth, and so I worked with a lot of the Medicaid population. And a lot of the population that you guys work with, the child welfare system, the child welfare kids, I worked with the court systems, the guardian ad litem. I know what you guys do, and I want to thank you for the work that you do for our kids. I began my career in managed care, so I left direct care and started working for the health insurance company in Kentucky Spirit, in the same community that I worked for with the Community Mental Health Center. And part of my job as the clinical supervisor is that we would watch those kids that were going inpatient. And we would see, we weren't in direct care, but we would see the names that would come through, and we would assign a case manager to them, and then we would get with our clinical team and we would talk about, why did the child go inpatient? Why did the child need this residential level of care? And we would try to problem solve and be advocates and and think about what were the other resources that we could have put in place for those kids. And about 3 months after I had left the community mental health center, those names that started coming up were names that I recognized because they were kids that were part of the after-school program that we ran or the girls group that I was a part of. And I thought, man, those kids and those families, if they had the right resources, they wouldn't be going inpatient. And I found out that those programs had closed. And I just thought, if there was a different service out there that was covered, or there was a different service that could wrap their hands around those kids and those families, then they perhaps wouldn't need to go inpatient, or they wouldn't need to go into those residential settings. So how many of you guys have advocated for children that ended up going into a level of care that wasn't in the community, residential, targeted case management, targeted therapeutic group care, or SIPs, that you thought, man, if there were just some other services out there to wrap those kids up and wrap those families, that maybe they didn't need those services, right? Show of hands of how many people that have experienced that. And so we're really excited about these new In Lieu of Services because we're hoping that these are going to provide some of those as options, some of these services as options for a higher level of care services so that our kids can stay in the community, because that's what we all want, is for them to be able to stay in the community. Now, that's not to say that there are kids and adolescents that need that inpatient stay. If they are going to be a harm to themselves or others, those are the appropriate levels of care. But what if there were different services that we had access to, that we could provide appropriate services to keep them stable in the community? So today, what I hope that you guys learn is what are in lieu of services. So what does it mean? What does in lieu of services really mean? What the new in lieu of services are that are offered by Sunshine Health, and how the new in lieu of services offered by Sunshine Health can benefit the children served here in the Florida Child Welfare System. And at the end, we'll do some practical application, a couple of scenarios, and kind of talk through some of those. So what are in lieu of services? In lieu of services are alternative services in a setting that are not included in the state plan or otherwise covered by the contract, but are medically appropriate and cost-effective substitutes for state plan services included within the contract. So basically what that means is these are alternative services that are not normally covered or required by the health plans to offer as benefits. But AHCA has determined that these services are medically appropriate and cost-effective substitutes for a traditional Medicaid covered service. So there are 4 elements to the CMS final rule related to in lieu of services. Number 1, and this is an important one, the state determined that the alternative services or settings is medically appropriate and cost-effective substitute for the covered service or setting. So the health plans had nothing to do with the creation or the determination of the in lieu of services. AHCA was responsible for that. Second, the enrollee is not required by the health plan to use the alternative service or setting. So these are optional services. These are additional services, and they are not required. There's always a choice in using one of these services. Thirdly, the approved in lieu of services are identified in the health plan contract and will be offered to enrollees at the option of the health plan. And fourth, the utilization and actual cost of services are taken into account in developing the component of the capitation rate. So I can't stress enough that these services are additional options for our members and your clients and our kids. They are not required. So the Agency of Healthcare Administration, AHCA, requires health plans to request approval for in lieu of services in order to provide member care by using alternate services or settings covered under the Florida Medicaid state plan. So as you guys are aware, and if you're not aware, AHCA just recently reprocured the statewide Medicaid Managed Care contracts. Effective date was December 2018. And Sunshine Health is over, once again, for the next 5 years, holds the child welfare specialty plan. AHCA determined the in lieu of services that each health plan could offer, and each health plan had the option of selecting the in lieu of services they propose to provide to their members under the new contract. So they are unique. They are unique to each health plan. So what that means is health plans got a list, basically, from AHCA that said, here are all the in lieu of services that you could provide. And the health plans uniquely picked which ones they wanted to provide. They could provide none, they could provide some, they could provide all of them. And they wrote AHCA back and they said, here's what we would like to do. And then AHCA approved each of those for the health plan. They vetted and approved which ones. So they're unique to each of the health plans. I'm going to try to move away from here for a second and see if I can give you an example. All right. So I don't know if you guys can see here. But if you see here on the left, we have the Medicaid state traditional plan service, right? And then we have the health plans in lieu of service. And you can see across the top that all the health plans, comprehensive plans, MMA only, and specialty plans, they're all up there, right? And you can see, if you go down the list, that they're unique to each of the health plans. So some of them decided and got approved by AHCA that they'll cover some, and others don't. And you can see, for example, if I point out mobile crisis, there were a lot of health plans that said, we want to provide mobile crisis. And Sunshine Health is one of those. Sure. Hey there. So we're going to get to that, okay? I'm going to go through, so that's a really good question. So I'm going to go through each of the ones that Sunshine Health, each of the ones that Sunshine Health will have in their new contract. And specifically what we're going to do is talk about those that we think will really benefit the child welfare, kids in the state specifically. So one thing to keep in mind as far as the role of the provider, the therapist, or who is going to be providing that service, and for the member agreement, just so that you guys are aware, is that the provider must educate the member on the in lieu of service as an alternative and optional service. The member must agree to the in lieu of service, and the provider must document member agreement in the medical chart. So what are the new in lieu of services offered by Sunshine Health? So just going over the 12 that we are offering, and then we'll come back and talk specifically about those that are specific to the child welfare.
On your terminology, who is the member? Educate the member must agree.
It's the client, I'm sorry, it's the client, it's the child, the guardian of the child.
So in most cases, it would be the case manager.
Correct. Correct. For the child welfare population, that's correct. That's a good question, yes. Okay, so the new in lieu of services offered is mobile crisis assessment and intervention, infant mental health pre and post testing, family training and counseling for child development, community-based wraparound services, self-help peer services, and then these are the ones that we're not going to be go into detail about today, but substance abuse short-term residential treatment, crisis stabilization unit, detox or addiction receiving facility, partial hospitalization services, and we can go over that, by the way, with your question, drop-in center, ambulatory detox, and nursing, skilled nursing facilities. So first, we're going to talk about mobile crisis. Are you guys aware of mobile crisis assessment teams? Have you guys heard of those? Okay. So there's been a big focus in Florida on mental health, specifically as a result of the Stoneman Douglas shooting. And there have been a lot of mobile crisis teams that have been created, 30 as a matter of fact, have been created across the state. And so let me move on to show you. So mobile crisis assessment and intervention. These are services that include on-site mobile crisis assessment, service referral, crisis intervention, and behavioral health triage services for members identified as being in acute crisis state. All efforts are made by the mobile crisis team to stabilize the individual in crisis and support them in access to ongoing behavioral health or other services to promote their stability. Mobile crisis services, and this is the cool part, is that mobile crisis services may be appropriate in a number of different settings. That's including the home, school, placement settings, emergency room, office, and other community locations. So basically, what these teams do is they get in their car or their van, and they go out exactly where the crisis is happening. So you guys are familiar with Baker Acts here, and let me ask you guys, how many of you guys think that, and there's a child that you guys are working with, and they get Baker Acted, and you heard the story, and you heard what was going on, and you thought, man, if there was somebody there that was trained in de-escalation, or maybe just a little more time, that kid could have calmed down. Just give it a little bit more time. Maybe that car ride over to the facility, they had already calmed down. That's what these mobile crisis teams are. These are behavioral health, mental health specialists that will have to include one licensed clinician on the team, and they go out to the emergency. And so that's why we're really excited about mobile crisis. And so currently, these services you might have heard of them because there actually are mobile crisis teams that are out there right now, and they're funded through our managing entities. So they're funded through DCF. And now, because this has been given as an option to the health plans to add this to our contract, we're working really closely with the managing entity to make sure that we're able to do even some cost sharing there, and those funds can be allocated in a different way for different services. So those that have Sunshine Health, they're able to be covered under Sunshine Health, and the other dollars can be spent towards other resources for our children. And so here's just a rundown, the billing code, and you guys don't have to worry about that, but it's in lieu of any emergency behavioral health care. So if we're afraid the child's going to end up inpatient or in the emergency room or readmitting, this is a good option for us in your community to say those mobile crisis teams. Do our kids and families have those numbers to the mobile crisis teams that they can call up? I believe that the requirement is within an hour of the phone call, these teams can get out, and they're 24/7. Okay, so this is an excellent resource for you guys, and I know that you guys aren't the therapists or the providers that are providing, and I know that our dependency case manager, the CBCs, or the guardians, but it's really excellent for you guys to know about these resources as advocates for these children.
Do you have that number?
Well, so there are different teams in each county, and then you would call that team. And we are still building our network. Because these are new, we're still building our network. But like I said, specifically for our mobile crisis, we are going to be attempting to get on board and on network as a Sunshine Health provider all of the mobile crisis teams that our managing entity is also using. Yes, sir?
Do you have statistics yet of how many people are actually treated by these mobile crises daily?
I don't have those.
So who would order that? The case manager?
Right. So the case manager, yes, could do that, and the foster parent could do that. So what happens is the provider is responsible. The therapist or the agency really is responsible for any of these services, whether the child meets that criteria, right? Whether they're appropriate for these services. In a mobile crisis situation, there's an emergency. We want to make sure our foster families have it, our biological parents have it, so that they can call up and those teams immediately go out there. Specifically for this service, because it's crisis, there's not even a prior authorization where they have to call the insurance company and say, hey, does this child meet? No, this is a crisis. So this is covered. This is covered, period. All the provider has to do, the therapist or the agency has to do, is just send us a bill, we're paying for it. Because it's that important for us to make sure that these kids are getting that particular service that could detour them from going to an unnecessary Baker Act or inpatient stay. Yes, ma'am?
You know, I am an accident attorney and I do special needs kids, and previously, I've also done since family, and previously I had been
Yeah.
for them. And I think it's wonderful.
Yeah. And, and so we're out in the community too now, and we're letting people know that these are covered services. We're trying to get providers on board to be able to, and part of that is law enforcement too, right? So law enforcement can actually utilize these services. They're called to a scene, and they can say, I'm calling a licensed clinician to come down here, and we're going to see if we can do some de-escalation here. And if it's appropriate, if they do need to be in the hospital, by all means, we want kids to go into the appropriate place where their needs are taken care of, right? But if there is a chance that we can stabilize a child in the community in an hour, in 2 hours, and then follow up with them, right? Then that's what we're hoping for the mobile crisis. And I don't know if you guys saw on the grid that I was showing you guys, but a lot of the health plans are now covering this service. So
Is there a list somewhere of the counties and the telephone numbers?
there is, and I can talk to you afterwards about it. Again, we're still building our network, and we're still in the middle of contracting, so there's all these pieces that go into that, and that takes a while, unfortunately. And so yes, I can talk to you afterwards, and I can pull that up and show you exactly. Okay?
Any care other than Medicaid?
For Sunshine Health.
Who's covering Sunshine Health?
So Sunshine Health as the managed care plan for the child welfare specialty plan. So I know that I know that there are teams out there that regardless, so if your child, let me just say this, if there's a kid that needs mobile crisis, they're out there. And they're not gonna they're not looking up like what insurance do they have, how is this gonna, they're gonna go out to the child and they're gonna see that. They're gonna see the child and they're gonna make sure that everybody's safe. But I can't speak to the other health plans that might be covering it. I know it's covered through the managing entity too as well. Okay, so let's go back for 1 second and go through this. So there are some service limitations, no more than 24 hours per fiscal year, so that's 2 calls a month. And the maximum is 2 hours per day. So eligible members are all ages who are experiencing behavioral health crisis and may benefit from the service as a diversion to inpatient, emergency room, or out-of-home placement. And the provider type, they are master's level behavioral health clinicians under supervision by a licensed behavioral health clinician. And mobile crisis teams must include at least 1 licensed behavioral health clinician.
Does the 2 hours start when they get to the situation or it departs on base?
That's a good question. I'm assuming when they get to the situation. So we will pay up to that 2 hours a day. We cover up to that 2 hours. All right, infant mental health pre and post testing. Has anybody ever heard of infant mental health pre and post testing? A handful of you guys? This was something actually that I learned more about when we decided to make this part of our benefits. So infant mental health, so the services are already covered for these children, but what isn't covered is the infant mental health pre and post testing. So how many of us think it's appropriate to have the right assessments for this particular age group? So 0 to 5, the right mental health services for 0 to 5, right? And this is a pretty unique age group because they can't talk to us, right? And it's really hard to know what service they need or where they need to go or what programs they need to go to. But the cool thing is now infant mental health pre and post testing, which has not been covered before, that is something that Sunshine Health offers. So what these are, the infant mental health pre and post testing, they're tests, inventories, questionnaires, structured interviews, structured observations, systemic assessments that are administered to help assess the caregiver-child relationship and to help aid the development of a treatment plan. So I'm sure that you guys all have experienced this too. When we have a child that's that young, how often is it only the child's issue that has brought them in? It's solely the child. How many of you guys think the caregivers, the parents, there's also an adult problem that's going on, right? right? So these assessments are really helpful in this way. So they focus on not just the child, they focus on the parents as well and the parents' development. And then they focus on the child-parent interaction. And so these assessments focus on, again, the child symptoms, child traumas, the child trauma symptoms, developmental functioning, parent-child attachment, observed parent-child interactions, parent or caregiver trauma history. How many of you guys think that the parent or the caregiver trauma history from their past could be affecting their child, right? The caregiver symptoms, the caregiver PTSD, and the caregiver mood, including depression and functioning. So some of these tests, so specific tests include the Parenting Stress Index, and it's a widely used and well-researched measure of parenting stress, clinical assessment behavior, adult attachment interviews, child behavior checklist, the CRAL, University of California at Los Angeles post-traumatic stress disorder, and I could go on and on about specific assessments that this will cover. And it's important because we want to make sure that we're really understanding the child and its family environment and what the child's been through interacting with the parent. And if we can really understand that, then that will help drive the clinical approach that we take with the child. So currently we're working with Dr. Mimi Graham, the director of the Florida State University Center for Prevention and Early Intervention Policy. She's been there since 1993. And regarding appropriate therapists out there, because we want to make sure if we're providing these services that those providers, those therapists are well vetted, that we really know that they're going to do a good job. And so we want to make sure that Sunshine Health is reaching out to our community partners and using those relationships with the people that really know this stuff and saying, hey, help us with this and help guide us in this. So we're excited with that partnership with her. Okay, and so there's the code up top you guys don't have to worry about. We do, medical necessity does apply. We get 10 hours per year for these assessments. A prior authorization is required, and this is for children ages 0 to 5 years old experiencing developmental delays or having difficulty bonding with caregivers who may benefit from specialized programs. So we think that we can imagine that this might be a very helpful service with early childhood court. Sunshine Health is supportive of the efforts to expand baby courts around the state and believe this would be a service that's incredibly helpful there.
So for the run-of-the-mill children who aren't in the baby court, can they access this?
Mm-hmm.
Okay, so do you need the evidence that the child is developmentally delayed before you're going to approve this?
So no. So there has to be concern from the provider, the clinical team, the guardian, that this could be a beneficial.
So how do they make those concerns? How do they raise those concerns?
Can you be more specific?
How do they raise the concerns about the child being developmentally delayed or having difficulty bonding with the caregiver?
So you would talk to the provider, you would talk to your CBC, your dependency case manager. So that's going to be the route that I'll keep coming back to, is that dependency case manager it is the guardian. And we have a relationship with the CBCs. We have a great partnership. And so you guys are expressing your concerns to the community-based care agencies, their dependency case managers, and they should also be they should be trained in knowing that these are services that are available in the child welfare specialty plan. Yes, ma'am?
They don't necessarily know because we're knowing about it now, right? But my concern is these recommendations may, include the therapy that you talk about, Dr. Graham. So who's going to provide the therapy on the individual circuits or the counties here on out? Are there identified providers that are trained in either providing attachment disorder?
Right.
Or is your goal to refer them to early steps or some other agency to promote the developmental delay issue?
So so the providers that we're looking to have on board are child-parent psychotherapists. They're certified child-parent psychotherapists. And so they are going to understand what all of those massive lists of tests are. They know how to identify these symptoms. They know, and so that's a really good question, because the testing really will be to identify if there's further need for any type of ongoing clinical treatment and what specifically it needs to go to. This is just the testing piece. And so those CPP-trained certified therapists will be able to get involved and be able to help with the further referrals to wherever they should go.
Okay, so it talked about, I'm sorry, the previous slide talked about difficulty bonding with the caregiver or the child's parent. So if the child's in licensed care and you want an assessment on the child's attachment or lack thereof to the parent, they will do that as well?
Absolutely.
Okay, so these changes theoretically are implemented when, July, you said?
They're implemented in December.
In December. So by then the CDC should have all the tools they need to implement these?
Well, ideally, that is the scenario this past December. So, right. And so what we would love is that everybody in the community is aware of all of these new services, we had a robust provider network or therapists, a lot of therapists and a lot of agencies that are on board, and that these numbers and to referrals were easily out there, but something like this takes time. And so they are in place, and we can help work with, go ahead.
So if we want these services, and we're not getting these services, because nobody knows about these services, do we contact Sunshine Health?
Yes, you can.
Okay.
You can.
I would tell the judge at the next JR.
You can. You can talk. You can talk to the judges, but again, going back to the CBCs and the dependency case managers, and they should be aware of these services. But again, these types of things, it's good for all parties that are involved to understand what the resources are, because there could be somebody that new came on board, or perhaps they haven't gotten the training yet. We just haven't gotten out there and gotten them the training yet. So it's good for you guys to know that, because you guys can say, hey, wait a minute, there are these services. How can I figure this out? Oh, call Melissa. Call Melissa Mott at Sunshine Health, because she'll be able to help you.
Have you trouble with professionals signing up to become part of the program due to reimbursement?
Sometimes. That is unfortunately part of it, yeah. Any other questions? Okay, so again, for the provider type is master's level practitioners that are under the supervision of a licensed practitioner in the healing arts, and has 2 years experiencing working with recipients under the age of 6 years old, and they must have training and expertise in infant, toddler, and early childhood development, and the observation and assessment of young children under the age of 6, which includes 20 hours of documented training required in the following areas: early childhood development, behavioral observations, developmental screening, parent-child intervention and interaction, functional assessment, developmentally appropriate practice for serving infants, young children and their families, psychosocial assessment and diagnosis of young children, crisis intervention training. So these providers that we are bringing on board, we want to make sure they really know what they're doing. When they're seeing these kids and these families, they really are qualified to provide these high-quality services. The next service is our family training in counseling for child development. And so this is a cool service because the child or the adolescent doesn't actually have to be present for this service. So these services include support groups or individual sessions for family members of the child or the adolescent that provide education regarding child development, emotional disturbances in kids, family education, individual support, psychosocial activities, and other education and support activities related to serious emotional disturbances in children. Services assist the family of a child and the needs of the member to enhance their development. Again, the child is not required, the adolescent is not required to be present. They can be if appropriate, but they're not required. Family training and support does not include services that require professional clinical license. However, services must be consistent with their qualifications. So here's the code again. We do apply. Make sure that this is a medically appropriate service. They get 9 hours per month with this service. And again, this could be parents. So this could be a group that is ran that is specifically talking about a certain diagnosis of a kid. So an ADHD group, support group for kids, or specifically focused on particular kids related to the diagnosis that they might have.
I'm sorry, I'm just having a hard time understanding how a bachelor's level behavioral health practitioner under supervision can really help with a child with serious emotional disturbances.
So the bachelor's level, they have had some training, and they've had training in behavioral health services, and they are under the supervision of a licensed behavioral health clinician that is overlooking those cases, that can be there in the support groups. They can be there and making sure that the treatment plans or whatever that they are utilizing as skills and coping mechanisms for the parents are appropriate.
Excuse me, do the parents or caregivers have to also be covered by Sunshine Health to take advantage?
Nope, and that's the beauty of this service, is it's the child, and the child doesn't have to be present there.
The child does not have to be under Sunshine, it can be under Magellan or one of the
No, the child has to be under Sunshine, but they don't have to be in the room or part of the, because sometimes what we need to talk to our parents when the kids aren't in the room. There are things that we do need to talk to these parents that are taking care of these kids, and that might be something that the child doesn't need to hear or be a part of. Yes?
Would you say that, kind of involving the question of the bachelor's degree in behavioral health practitioner, is this going to be usually somebody who's going to get their MSW?
Correct.
And they're working towards
Their licensure, correct. Right. Right.
So you just said parents, and the slide says caregivers. So let me just give you a scenario. If you've got foster parents who are having challenges with the child's behavioral issues and the integration into that foster
Yep.
family, then that family or those foster parents would qualify for this type of...
That's correct.
Okay.
That's correct. So the child has to be under 21 years old. They have to have an STD diagnosis, and the child and family, the family has to be willing to participate, obviously, in this service. All right. And then we have community-based wraparound services. Have you guys heard of community-based wraparound services? If you guys have been to conferences, it's been a hot topic here for the last year or so. So we're happy that we're able to provide community-based wraparound services. So community-based wraparound is an individualized care planning and management service for children with complex needs. Services include structured, creative team meetings and care plans that are designed to meet the unique needs of the recipient, caregivers, and family across a range of domains. Wraparound team meetings include the full complement of the child's treatment team, social supports, non-traditional supports, and the family members. Services are provided at flexible times and locations to accommodate the needs of the child and family, and then treatment service plans are frequently reviewed and updated as needed. The emphasis is on integrating and maintaining the recipient in the community and building the recipient and family social support network. So this is in lieu of therapeutic group care or SIP placement. So if we have a child that is meeting the criteria and then we're worried about that for therapeutic group care or SIP, this is an option for them. So let me talk about wraparound for a second. Wraparound is a word that in the health industry can be used a lot of different ways. We wrap our arms around the kids and everybody on the team that's working together. We're all working towards a common goal, and so we might consider those wraparound services. I know I use that a lot when I was a therapist. But community-based wraparound is actually a model. So there are particular elements and practice principles that actually guide this model, all right? And so, for example, wraparound must be in the community. The wraparound approach must be a team-driven approach involving the family, child, natural supports agencies, community services working together to develop and implement. The families must be in full and active participation. Services and supports are individualized. There's wraparound plans, there's team meetings. There are particular standards of this model that have to be used. And there are several, so targeted case management agencies are the ones that are certified in this wraparound model. And those are the ones that are certified through the state as this wraparound model are going to be the ones that are going to be participating in our, as a Sunshine Health provider. And so, again, it's in lieu of therapeutic group care, or SIP. Medical necessity does apply. And this is per day, prior authorization is required. This is for members 0 to 21 years old with a serious emotional, so a SED qualifying diagnosis, who could benefit from community-based wraparound services as a diversion to higher levels of care. So we're really excited about this one. If you haven't gone to a training about community-based wraparound services, please do so at one of your next conferences, or learn about this service. This is an excellent resource.
Who's the team lead in that case? Is it the SIP?
So it's a separate, okay, so it's a separate service than SIP. So let's say we have a child and the suitability recommends SIP level of care. And the clinical team and the dependency case manager and CBCs, they come together and they say, you know what, I think with this community-based wraparound model, where the child stays in the community and in the home, and we wrap these services around at all times of the day, and they have, they're very flexible with the types of services that they can provide, that we can manage this child in the community. And so the targeted case management agency is the one facilitating kind of the model and making sure that everyone's staying on the same page. And it's been very, it's an evidence-based practice, and it's been very effective, yes.
So is that write your same report, or does the team lead put a multidisciplinary report that brings everything together?
That's a really good question as far as the technicalities of that. I believe there's going to be one report that is managed.
Because it's Gail's, we're certainly not competent to read a bunch of reports and pull everything together.
And so there is that facilitator that will make sure that everyone is on the same page, making sure that they're talking and everyone understands what the goals are there. So the practitioner, so the therapist, they must obtain complete wraparound 101, which is the training, or a similar health plan approved wraparound training prior to service provision, and must obtain certification as a wraparound facilitator within 1 year of completion or approved initial wraparound training. We also have community-based wraparound services. Self-help peer services. How many of you guys have heard of peer services? So what peer support services are, they're provided to members with mental health or substance use conditions, provided by certified peer support specialists with similar mental health or substance use experiences, are in recovery, and are trained in delivery of effective peer support. So these aren't licensed clinicians, they're not behavioral health, they're not connected to the system. These are their peers. These are friends that are in a recovery model. They have experienced their own mental health issues or substance abuse issues. And you link these children and families up with these supports, and they are incredibly effective. As you guys can imagine, they'll likely talk to that peer support specialist they're linked with more than they would talk to a therapist. They would probably be a lot more honest about some of the other things that are going on. So this is why this is a really effective service. So we're really excited about this service specifically for our transitioning youth and our independent living teenagers. We are currently working with Camelot in our Tampa region, identifying peer specialists for our transitioning youth teenagers. And the idea is that the peer specialist would have actually gone through the child welfare system and understand what that's like. So we're pretty excited about that. Here, again, are the codes. Prior authorization is required, and this is for all ages with mental health or substance abuse disorders. And again, the provider type is certified recovery peer specialist under supervision of licensed behavioral health clinician.
So once a child is identified that will benefit from that type of service, the case manager or head Litem would contact Sunshine or that provider?
Or the provider. The provider that would provide the service. So contacting the community-based care agency and saying to the dependency case manager, I think that this child could really utilize, it would really help to have a peer specialist on this case. Then the CBC could say, here's the peer specialist in your area. Then the provider will have to request that. The provider has to request those services and say.
So Camelot would know where to get this service.
Right. And Camelot can provide that as well.
They don't do it, I'm just no annual. There's no annual limit.
Oops. It looks like that. I'll have to get back about that. Looks like we forgot to put that one. So the provider is ultimately who's going to be reaching out and saying, we'd like to provide this service to the health plan. But the dependency case manager should be involved in those. Okay, so I wanted to go through a couple of scenarios with you guys. And we can talk through what you guys think. So scenario 1, a 14-year-old female is engaging in highly sexualized behaviors, substance abuse, school truancy, and petty theft. Youth frequently spends nights out without foster parents' permission, and her whereabouts are typically unknown. Youth has explosive, angry outbursts and reports incidents of possible sexual abuse, but she will not disclose the details to authorities. Youth has a history of multiple Baker Acts and has already unsuccessfully engaged in individual therapy, family therapy, therapeutic behavioral on-site services, and targeted case management services. Youth is at risk for expulsion from school and DJJ involvement. The team believes a higher level of residential care, specialized therapeutic foster care, or statewide inpatient psychiatric program will be needed if the youth is not stabilized. Foster parents and natural supports are willing and able to engage in her care. At this time, an in lieu of service is being considered by the dependency case manager and foster parents who would agree to an alternative before STGC, specialized therapeutic group care, or SIP. So what in lieu of service may be beneficial to consider for this youth as an alternative to secured residential placement? Psychosocial rehab, self-help peer support, community-based wraparound, or drop-in services. What do you guys think? All of the above, yes. So the most appropriate here would be the community-based wraparound service. So again, this is going to be the most robust, fully wrapped around services that this child can get. And it is the service that is in lieu of a higher level of care. So if we're talking about a kid that's already meeting criteria to go to therapeutic group care or to go to a SIP, then this is the most appropriate service for them, is the community-based wraparound service. And again, the description. All right, scenario 2. We have a 2-year-old child with limited ability of communication, poor eye contact, and appears to have reactive attachment to caregiver. Child was removed from her biological mother due to mother's substance abuse and depression. The child appears to be suffering from developmental delays such as speech, motor, and relational attachments. Further assessments may be needed to assess for diagnosis and appropriate treatment programs, including consideration of child-parent psychotherapy. The team is also considering referral to the case to early childhood court. So what in lieu of service would this young child benefit from? Infant mental health pre and post assessment, self-help peer support, family training and counseling, or a crisis stabilization unit? Yeah, A and C actually. A, so we have A because it talks specifically about the attachment pieces and the further assessments that are needed, right? So the assessment piece then would be infant mental health. But you're exactly right. They could also benefit from that family training and counseling. Yeah.
Can they get them at the same time? Are they eligible for multiple?
So we have kept these services open. As far as I know that there's concern sometimes because the child is getting this service, they can't get this service. So we've kept a lot of these services open to have those conversations because, my goodness, yes, we would like for, and the infant mental health pre and post testing and the family training, the infant pre and post testing could actually guide the family training and counseling treatment. That's what it's really going to be used for. Yay, you get a prize, infant mental health, okay? And then the last scenario is we have a 12-year-old female who was removed from the home at the age 8 and has recently been displaying increased anger, defiance, and eloping behaviors. The child has a STD diagnosis. She's currently receiving outpatient therapy, but attempts to get her behavior under control has been very slow. Foster parents report that they are lost. They do not know how. They do not know how to properly administer her medications and do not know how to best approach her when she's moody. The foster parents do not want to pull her out of her individual therapy as she's bonded with the therapist. How many of you guys have experienced that? So they've bonded with their therapist and then they change services or they change locations and then they have a whole new therapist. So they don't want to do that. And while progress may be slow, she's making some progress. The foster parents are willing to engage in treatment in lieu of therapeutic behavioral on-site services, TBOS. Which service would the child benefit from? Psychosocial rehab, community-based wraparound, partial hospitalization program, or family training and counseling? So we got a B, community-based wraparound, family training. D. Yep, the answer is family training and counseling. So again, family training and child development services include support groups or individual sessions for families that really provide education on the child's diagnosis. That would include how to administer those medications and some of the things those scenarios said. Okay. Do you guys have any questions?
Do you know how many SIPs are informed?
How many SIPs are in? Not enough. Yeah. I believe there are around 10, I want to say. 10 or 11. Any other questions? So for additional information here on sunshinehealth.com, our website, you can find that. And I've passed around my business cards too if you guys have any questions. They are. They're on the website. And then also, I wanted to show you guys, let's see. So we do have a behavioral health in lieu of services resource guide that is in printing currently. And I tried to get them mailed here to the hotel, and I wasn't able to give out to you. But this is what it looks like, and it goes over in detail all of the different in lieu of services. So I just wanted to go through this really quickly. So we have, you can see here, it's a little booklet of the ones that we went over and the ones that we did not discuss. But it goes through the description of each of the in lieu of services. So if you guys are interested in this, I have a sign-up sheet right here. If you guys just don't mind leaving your name, your email, and your address, we'll actually send some to you, some booklets for you guys to have.
Will they be posted on the website?
Yes, they'll be posted on our website as well. Oh, sure. Sorry. They'll be posted on our website as well. So you guys can sign up here. Just leave your name, your email, and your address, and we'll get those books to you guys. They should be in our office. They're really pretty. They should be in our office by the end of this week, and so we'll try to get those out in the next couple of weeks. Any other questions? Yes, ma'am?
Melissa, I want to make a statement because I sense the same frustration. I'm a volunteer.
Mm-hmm.
And so this has been very informative, and I think all of us could say, oh, that applies to one of my kids, or wish my kid had that service. But we're almost like a broker, because our authority, the real authority to reach out and do the referrals and everything belongs to the case managers.
I know.
And a lot of times they are not as well informed or as responsive as we want them to be. Sometimes they're even more resistant if you come and you say, here's a program I want the child to be enrolled in, and it even actually backfires on you. I think that's some of the resistance I know that I have experienced. And I guess one of the things is, should we reach out directly to the caregivers? Should we reach out directly to Sunshine Health ourselves? Continue to work the system with the case managers whose responsibility and authorities as the guardian of the child make them responsible and give them the authorities to do that.
Right.
That's kind of the frustration that
I know.
volunteers have.
I know it is. And I've heard that in different settings as well. But we go back to the dependency case manager as the guardian. Go ahead.
So every CDC has a behavioral health coordinator that can assist with that. So if you have a child who maybe doesn't rise to the level of needing a multidisciplinary team that a BHC would run,
All give up. When we have a voice,
then the behavioral health coordinator can help connect and coordinate this type of care.
So
So I'm with the Attorney General's office, and it's situations like that, I understand what you're saying, but honestly, the best way to work it is talk to your attorney. If your attorney approaches us, then we all know what's going on, and we can't fix things that we don't know about.
well, and that's why I sarcastically put it. You can't get anything else done, put it in front of the judge, and make the judge go right, see how you can do it. And you can't play dirty in court like that. Sometimes that just makes like talk rather than like footsie.
So going back to what was said about our behavioral health coordinators, so there's a behavioral health coordinator and a nurse coordinator that is that every CBC has, and they are partners with Sunshine Health. They're in the agency. So if you guys are having difficulty, you can reach out to them. I can help with that contact information, who your behavioral health coordinator is in each of the CBCs, and you can work through them as well. Yeah. I know that you guys are advocating in every way you can, and it seems like sometimes it's just hard to get through where you need to get through, right? And so I know as advocates that can be very frustrating, and so that is one resource where you have a direct line to someone that is part of Sunshine Health, that behavioral health coordinator in the community-based care agencies. And if you need to know who that is, I can definitely get you contacted with that person.
Oh, never mind this. Because we do MDTs, that's an excellent suggestion to bring it up during an MDT. It's a part of the process. That's a part of the process. And last resort, I don't know, like I said that facetiously out of school, but it's true. Yes.
It is. And in the MDTs, we have, if the child has a Sunshine Health case manager, they should be well-versed in these services as well. And so they should also be saying, hey, what about this service? Because they work for the health plan. They're the ones that know everything about these in lieu of services. So you'll likely have an advocate there as well.
Does Sunshine Health evaluate by SIP which are the best services? Let me just give you a quick.
Okay.
I had a kid in the newspaper, crushed down, okay? Her sister saw it. So the decision was made, she's got to go into inpatient care. So I went to when they said bring a second psychiatrist in to make an evaluation, I went with it. So he talks to her for about 2 hours and sent her to the room and said, anybody got anything else? I said, I just want to be sure she goes to the right place. Here's what they're thinking about sending her. He looked at me and said, that child does not belong in that SIP. The and you call me to testify, I'll deny or say. What I do with that information?
So,
So do you guys evaluate, and I call you and say, here's a problem, is that set the best place for her? And by the way, she was supposed to go 90 days, she went 180 days, and that's what we got her. And I'm her advocate.
right. I know that there's frustration with scenarios such as this, and I would like to talk to you about that, if we could talk about that after, because I know there are going to be scenarios such as that, and I know. But we do our very best to work with the clinical team, where we are on those multidisciplinary teams. Do you want to say something?
We do have the listing of what SIPs specialize in, and it might be more appropriate, it's going to be more positive of the way you're saying. We're not going to say, don't place here, but kind of the populations that they specialize in.
If there's 20 disorders, and this one is good for 10, and my girl's got 3 that aren't in that 10, I don't want her to go to that one.
So maybe it would be a helpful tool. It's not going to be the perfect solution, but we can provide it.
Right.
There were 10, by the way.
That's what I thought, 10. I thought there were 11, but, yep, okay, gotcha. All right, guys. It is 5:22. I'll let you guys out a little bit early. If you have any questions, stick around. I'll be here. Thanks, you all.